Yo people, welcome to Made Non-Toxic. Today we're going to discuss a topic from medicine, right? One very important topic, that is facial paralysis and paralysis. So when I say facial, is related to the face. Paralysis means a weakness or paralysis. So the most common cause of facial weakness or paralysis is facial nerve palsy, right? That means the seventh cranial nerve palsy. Another name for it is Bell's palsy. We'll get to why it is, okay, at the end of this. Now, this is some common causes other than Bell's palsy, right, that results in facial paralysis and paralysis, and it's divided, right, systematically into things in the central region, right, that is brain abscess, multiple sclerosis, poliomyelitis. In the intracranial part, right, you could have acoustic neuroma or congenital cholesteatoma leading to facial paralysis. You at the intratemporal part, okay, one of the main causes of facial paralysis is Bell's palsy, or infections, very important, herpes zoster infections could lead to facial paralysis, right, or glomus jugulare tumor could lead to facial paralysis. Another very important extracranial cause is neonatal facial injury due to the use of obstetrical forceps during delivery. That has been observed to lead to facial paralysis, so that is very important, right? And then obviously your systemic diseases such as diabetes mellitus, hypothyroidism, and leprosy. So things that I really find important is diabetes mellitus. Remember that that's a risk factor for Bell's palsy as well. Hypothyroidism is important. Leprosy, okay, very often I've seen a case also where the individual has sarcoidosis. Neonatal facial injury is important. Herpes zoster or ticus is important, so remember these few things. And obviously Bell's palsy itself. So we are talking about Bell's palsy today, right? So as you know, Bell's palsy is also known as facial nerve paralysis. It is the most common cause of facial weakness or paralysis. So the problem here is with the seventh cranial nerve. There is a lesion in it within the facial canal. As you can see in these pictures, it affects both sexes, male and female, and all ages, okay, from a pediatric age group all the way to adult, okay. A mean around 15 to 45 is where you see it commonly, right? Now, etiology, coming to the etiology, very often it's stated it's an idiopathic cause, or it's also known as idiopathic peripheral facial nerve palsy. However, it is gone to seen, okay, through many studies done, that the pathophysiology remains the same. It is observed as inflammation of the facial nerve with mononuclear cells, right? And this inflammation with mononuclear cells is very consistent with an infectious or immune cause. So it is gone to see that or it's observed that very often it's associated with herpes simplex virus infection or varicella zoster virus infection, right, or various other viral infection, okay. So although idiopathic, it is noted that it could have a viral background, or also observe, right, after vaccination, post vaccination, especially of the intranasal influenza vaccine. So viral or vaccination could be the cause, okay, clear? Now the clinical features is quite easy to remember. Okay, I like this picture because it goes very systematically from the top to the bottom, right? Now the onset, first of all, is quite abrupt. It's very sudden. Okay, within few hours the individual realizes, okay, I've got something is wrong with my face, right? So what it starts off with, okay, not in any particular order, but this is what the patient will observe. That drooping of the face is the first thing patient comes. Okay, this facial droop is the first thing the patient complains of, where the face becomes asymmetrical. Okay, as you can see, this is the face, so loss of symmetry. Down from the top, first of all, there will be loss of wrinkles, no more wrinkles. Unable to close the eye, okay, so that is called lack of thalamus, okay, the lagging of the eye. And if I try also to close the eyes, what happens is my eyeball starts turning up and out. So that is known as the Bell's phenomena. Very importantly, I will observe, as you can see, epiphora, tears flowing down my eye. There is also saliva dribbling from the angle of the mouth, right? And pain in the ears. So it's quite easy to remember it. And again, if I look at this another picture from the beginning, so the facial asymmetry is lost, right? There is loss of wrinkles, unable to close the eyes. Okay, together with that, if I try to close, the eyes moves up and out. That is known as a lack of thalamus, right? Obviously here I can't see the tears falling down or the saliva dribbling from the angle of the mouth. Often there would be pain in the ears as well, and noise intolerance, right? Quite simple. And on examination, what I will observe is that there will be an ipsilateral, that means only on one side there will be a lower motor neuron type of weakness. Also together with that, if you observe in this picture, often I would find vesicles in the ear. Okay, that indicates I've got an herpes zoster infection, and herpes zoster infection would be the underlying cause. So diagnosis of the disease is quite simple, right? It is clinical very often. So you've got the typical presentation that we just spoke about. That is number one. There are no other risk factors. That means no diabetes, right? Or individuals, not having hypothyroidism, or various other risk factors above that we discussed. Absence of the cutaneous lesion of herpes zoster in external ear canal, and a normal neurological examination except obviously the facial nerve, right? So it's very easy to diagnose. How obviously in atypical cases or cases where you are uncertain, then you're going to go for like the test for diabetes mellitus just to rule out, or a CXR to rule out sarcoidosis, right? So investigations to confirm your diagnosis, right, is go for your CSF fluid. What you will observe is mild lymphocytosis. Do an MRI. An MRI is very important, right? What you will observe is here this enhancement, okay, a uniform enhancement here and here, right, with the swelling of your geniculate ganglion and facial nerve. That is quite easy to reach a diagnosis of Bell's palsy. So two important in investigation, your CSF is going to show mild lymphocytosis, MRI is going to show uniform enhancement and swelling of your ganglion and facial nerve. You can obviously do electromyography, just that only has prognostic value, nothing else, right? And then you come to the complication. So very often there would be recurrence of the problem once there is resolution, right? Or what can also happen is something called aberrant re-innervation, right? That means it re-innervates wrongly, giving rise to unwanted facial movements such as eye closure when the mouth is moved, that is known as synkinesis, right? And crocodile tears, that means tearing during salivation. So what is the prognosis? So if in 1 week the paralysis becomes incomplete, that is a very good sign that, you know, I'm heading towards, or the patient is heading towards recovery, right? And most of the time there is spontaneous recovery within 12 weeks. Okay, within 3 months it is fine. Now if within 3 months that doesn't happen, that means most of the time that weakness will be there persistently, okay, or forever, right? Then coming to management, symptomatically, first thing is to use a paper tip, right? That is to prevent corneal drying or any abrasion or keratitis. Very important is to massage the weakened muscles. So importantly, you need to do facial muscle movements. That is the most important thing. Medically, I can give steroids, okay? That is normally prednisone is a choice. It's given daily during the first 5 days, and then you slowly taper it over the next 5 days. Do I give antiviral drugs? No. Okay, it has proven to be not effective, right? And surgically, I take a surgical management when there is a facial disfigurement even after 12 months. Then I will opt for plastic surgery. Sometimes I can also opt for nerve decompression surgery, right? So by the way, why is it named Bell's palsy? Right, it is named after the Scottish anatomist, surgeon and physiologist who described it in 1821, right? So thank you for watching. If you liked it, hit the like button and the subscribe button. You can follow me on my Instagram page, Made Non-Toxic, and do give suggestions, constructive suggestions down in the comment box below. Thank you.